today. As you will see, I call this the Via Dolorosa or path of pain. And women with endometriosis should be looked at as a chronic disease. And unfortunately, till now, we cannot tell them that they have a cure. Because when they start their first period, they will have pain, and they will continue all through their life with multiple surgeries if they are unfortunate, and bad, dodgy medical treatment if they are unfortunate again, and most of them are either they will face infertility problem, you all know that, and even as Professor Oral have shown us, even after the cessation of reproductive function, they may still be at risk of the endometriosis effect, as in premenopausal and postmenopausal, or either if they will go premature ovarian failure if they had bad multiple surgeries for the ovaries, and they may end up either in total abdominal hysterectomy or long-term comorbidities with endometriosis. And all of that because the concept of considering endometriosis as a surgical disease has been embedded in our minds since we were medical students, that endometriosis is solely a surgical disease and only can be dealt as the old days when a caveman came with a knife and a fire. That's what we are doing in surgery with endometriosis. We are cauterizing and removing, and all of this should be changed. And changing your mind by changing your perception. And as doctors, we owe these patients to change how we perceive this disease, and with more pathophysiological explanation why this disease is happening, why the symptoms. Although it's enigmatic, but we have done a lot of good job in the last 30 years of understanding this disease. And today I was very pleased that there is a shift in thinking. There's no more diagnostic laparoscopy for endo. And laparoscopy should be done if indicated, only with intention to treat. And surgery should, patient, they should know, we owe them that it is not a cure. And I'm seeing more and more of surgeons, including myself, that we have become wiser and changing and accepting that there is other things to do for and to offer these patients. And if you look at the integrated elements of evidence-based medicine, which we all look for, that you must have an evidence and your own experience, but don't forget, please, the patient's value, how they think, what they want. This is very important in dealing with endometriosis. And today I have seen that a lot of people have constantly focused on what the patients need. And Ghassan did a very good job at making the first session about patient focus groups. And issue regarding the pain management, either by medical or surgery for deep endometriosis, showing that the quality of studies to have evidence-based medicine are not strong enough to make a valid conclusion on either ways, medical or surgery. Lack of clear guidelines regarding the optimal strategy. These guidelines are different and are not fulfilling all the requirements to have an optimal, best standard management. Progressiveness of endo, I will talk about it. Effect of surgery on the tissue. This will be another talk. And the recurrence rate of care, of course, today some speakers have touched on that. Complications of surgery and long-term effects of surgery on fecundability and fecundity of these ladies. Possible side effects, of course, of medical treatment. We still don't have yet the magical cure for endometriosis. And the effectiveness of these medical treatments and longevity of medical treatment is still an issue that I will be touching in. Surgical services in our region, real situation. Most primary surgeries are performed by general, not highly skilled surgeon. And we all know the first surgery, the most important. And I said loss of virginity of these patients during first surgery. It either will be done by a Rocky or a general surgeon who discovered endometriosis. And this is the lack, because of the lack of taking good history from these patients. Surgical mentality of adhesolysis rather than disease removal. And this is the case with OMA. Most of the surgeons are concerning about what they are seeing. And we need to know that they understand the background of this disease coming from the pelvic side walls. And the main disease must be removed from the pelvic side wall before approaching the endometrioma per se. Lack of centers of excellence, especially in our region, although there is some humble experience with this, but we're still lacking real centers for excellence. Not well-established multidisciplinary approach. Surgeon, gynecologist interaction, we don't talk to each other. I have seen many surgeons who think endometriosis is just an adhesive process. Surgery is highly operator dependent, and the care skill to have a very good skills need time. And this is a call for separating the gynae laparoscopic surgeons from the residency program of obstetrics and gynecology, because they are losing a lot of time, wasting a lot of time just learning skills that they will not use. Most of the surgeon, laparoscopic surgeon, will start their training at the age of 30 or more. Surgical versus medical, what's the real situation? No studies have directly compared medical versus surgical approach to endometriosis. Therefore, no substantial evidence exists to establish the superiority of one approach over the other. Till today, I have looked really till a few hours ago about any studies that comparing this in a very solid way. There is no lack of studies. In a systematic review, however, of 23 studies and in more than 1,800 patients, there was no statistically significant pain improvement after undergoing surgical versus medical treatment. And although this systematic review looked at studies with different quality and methodology, however, the studies were having a high risk of bias in blinding, selective outcome reporting. Not all studies are reporting the real symptoms, presenting symptoms, and selection bias, of course, because most of these studies are done in high skilled centers for endometriosis, so there will be some bias. However, a German study indicated the overall pregnancy rate were unrelated to therapeutic treatment choice when comparing exclusively surgical, medical, or combined therapies. And this is adding to the debate again we had all morning about what's the best way to deal with patients with deep endometriosis. In a review by Singh just being published about the surgical outcomes on research on endometriosis, a systematic review, the results, total of 38 studies were included. Most studies did not report relevant outcomes to evaluate pain in 70%, and in almost 70%, the recurrence of surgery. Of the women who underwent lesion excision, reported no improvement in pain, 22 underwent further surgery. Of the patients who were treated surgically for deep endometriosis affecting bowel or bladder, 7% experienced recurrence of symptoms. And this is high, 7%. And we are talking about a timeline, maybe in 10 years, she will have double or triple trials of surgery. And 4% of these underwent further surgery. And if you look at the guidelines by all of the main societies, surgical intervention should only be considered if trial of medical treatment have not been successful. Laparoscopy may be better seen as a second-line investigation. There is no evidence to support the division of fine adhesions in women with chronic pelvic pain. Women with cyclical pain should be offered a therapeutic trial using hormonal. And I have an objection against therapeutic trials. Should be a real intention to use this hormonal treatment and juggling between these different types of treatment. And laparoscopy should be considered if adolescent with chronic pelvic pain who did not respond to medical treatment. We should not take all adolescents with suspected endometriosis to surgery and making them already a surgical case. And they should have non-steroidals, oral contraceptives, progestins, or other modalities of treatment. And this was announced by the ESHRI. The problem with the surgery that most of the surgeons think that it is a progressive disease. And I think among our friends here who believe that. I used to believe that because it's all started with the red wine study, the famous one, about the main age of lesions type and the finding at laparoscopy. And they thought that it is a progressive. However, hands have shown in his nice publication, The Humor Production, a few years ago, that a regression occurs almost in 40% of these patients. He looks at multiple studies, although the number of patients were very small, with no change 40%, and progression only, 29%, and only 1/3 of these patients will have progression. So the question about whether it's a progressive disease or not is not clear, although I'm keen to think that it is. The natural history of endometriosis is not clear, and I'm keen now it's not progressive as we used to think. Now look at when endometriosis and trauma itself. Trauma, as you know, to the tissue trigger endometriosis by activation of adrenergic signaling, which in turn suppresses cell-mediated immunity and promote angiogenesis and neurogenesis. I have been seen with the Australian team under Professor Fraser. Abdominal wall endometric nodules may induce by surgical trauma. This is, we all notice, which explains the phenotype of this disease. A prospective cohort study demonstrated that the risk of scar endometriosis in women with previous cesarean section have an increased risk of pelvic endometriosis, possibly suggesting that obstetrical surgical trauma to the tissue may facilitate the pelvic endometrioma. The recurrence rate is 2 times higher among patients who underwent laparoscopic surgery for endometriosis. And one of the speakers respected today have shown that when you go to the second laparoscopy, you find the same location of the previous, if you have done the surgery yourself. It is the surgery that enhance future adhesions in this maybe, I'm saying maybe, I don't have a solid evidence. Peritoneal healing takes 5 to 10 days, and the trauma occurring a few days before menses. So that's why luteal phase surgery may be different from follicular phase surgery. And all of this means that there is a trauma that's happening during the surgery. We are, again, treating with fire and knife. Trauma to the ovary. Samsung have proposed that the corpus luteum hemorrhagic cyst colonized by ectopic endometrium could be a cause of ovarian endometrioma. And this hypothesis, why, again, by Nizhad and Versellini. The epidemiology argument in favor of this hypothesis that multiple ovulation is the frequent physiological trauma that may cause this OMA. Growth factor released by the traumatized area may facilitate the implantation and growth of endometriotic cells. And Dr. Afar today have shown to us that indeed these endometriomas are affecting the reproductive capabilities of these women in the ovary per se, only the presence of the OMA. When looking at the molecular effect of trauma on tissue, growth factor release traumatized and may facilitate implantation and growth of endometriosis. And all these studies, this new study, all these studies have shown that activated platelets done by the team by Sun Wei in China, initial steps of tissue repair and proposed as a culprit in the development of the disease. This may induce estrogen receptor beta expression in the endometriotic stromal cells, which enhance further aromatization and increased local production of endometriosis. COX-2 production by monocytes, endothelial stromal cells, and activation is enhanced by the trauma. Surgery, it means. Tissue growth factor beta, a central factor in the regulation of peritoneal repair may be affected by the surgery. And elevated other inhibiting factors expression is high following the injury done by the surgery itself. Recently, Evaluate showed that an ectopic endometrial cells, E2, upregulated in the expression of MIF, which is the macrophage inhibiting factor, which induce expression of aromatase. Again, we are enhancing and making the right environment, local environment, for aromatization and estrangization of these local ectopic lesions and further development. And when you look at OMA, and OMA is a very important, and one study have shown that up to 70% it's associated with deep endometriosis. And today I was very pleased to hear that People are considering ultrasound before the surgery, considering a detailed history to look for deep endometriosis, especially in women with OMA. And surgery, as we said already, therefore should be the treatment for symptomatic or large endometriomas. Although I'm not sure what the cutoff or the threshold for a large endometrioma. And today we had some discussion with Professor Popov, and I agree. When you have large endometrioma, you may have more symptoms, and thus you may have an indication to deal with this OMA. And the factors that affecting our decision are multiple. Is it the size, the age, the fertility desire, the pain scales, previous surgery, or bilateral or unilateral? And today this has been emphasized by many speakers. And of course, the ovarian reserve in terms of AMH and antral follicular count. And by all means, with respect, in good surgeons, studies have shown that around 50 to 60% of endometriomas will contain oocyte when you remove them, in comparison to 6% with other benign ovarian tumors. And look at this slide. All these slides have shown that indeed the ovarian capability of having the reserve is affected by the surgery, cystectomy, or other ways of dealing with it. Either ovarian damage, frequency of ovulation, or serum AMH, or intrafollicular count, or even the oocyte harvested during IVF. In a nutshell, surgery to OMA is affecting the ovarian reserve. And here in this occurs in, even the horrifying diagnosis of premature ovarian failure of 2.4% of women undergoing cyst excision. And this is not an easy way of taking, an easy number to take lightly, and we need to think about it. Recurrence after surgery, many speakers today have spoken about that. It was variable, and lots of studies have shown up to 60%, 70% in the first 2 or 3 years, and more of that when they followed them after a few years. And if you look here, the time interval of recurrence and in different phenotypes, either superficial or deep endometriosis or OMA, and at almost 30 to 36 months is around 50%. And this study have just been published in the last year. So laparoscopic management of as a predictor of major complications. In one study, they have complications for following laparoscopic treatment for suspected endometriosis, all type phenotypes, could not be predicted by preoperative patient characteristic or surgical findings. And this is, again, saying that adhesolysis, surgery in the ureter, and increased number of the total procedures may be predictive or of perioperative complications, suggesting that surgical complicity as measured by procedures performed rather than the disease severity, which is again reflecting the enigmatic nature of endometriosis, may increase the risk of complications compared of women who do not undergo these procedures. So we still have, although good skilled surgeons, we still have a quite good number of complications and recurrence. And when we look at the rationale, why to use hormonal treatment for bowel endometriosis? Progesterone receptors are expressed not only in the ectopic mucosa, but also in the smooth muscles of the fibers that infiltrating the colon. The anti-inflammatory properties of progestogen may influence long-term fibrosis remodeling. Suppression of the gonadal activity should attain partial lesion regression or temporary avoidance of progression. Ferrero have shown that evaluating the variation of rectovaginal endometriotic nodule volume in women treated with progestogens as monotherapy, and if I'm not mistaken, it was a northistrone or norethindrone, or combined with letrozole, estrogen, progesterone contraceptives, they found and the nodule volume decreased by 20% after 6 months and 30% after 12 months, without significant difference between study drugs. nodule volume decreased in 74% of participants, but increased around 20% or in 12% of them. This is a good evidence that we have the basic to use progestogens for the treatment of bowel endometriosis. Look at all of these studies. Egekvist in 80 patients have looking at rectosigmoid, rectovaginal nodules treated for 12 months with the levonorgestrel intrauterine device, Mirena, which is up to my humble knowledge, the only progestogen that prevents new endometriosis from development due to atrophy of the endometrium and retrograde menstruation lacking. And he found that the nodule length and width increased in 9 of 6 patients, respectively. During the study period, surgery was required only in 6% of these patients. And I remind you, we are talking only pain symptoms. Later, assessed rectosigmoid nodules measuring a variation in 43 women who underwent 2 MRIs at least 12 months apart. Nodule progression and regression was defined. And what he found? He found that stability, progression, or regression were observed 60%, 28%, and only 12% in women, respectively. So 60% of them had a steady, no regression, no progression. Bera looked at 83% patients, and he found that endometriotic nodules regressed in half of the patients, remained stable in 35%, and only around 10%. As you see, progression under progestogen only occurred in these old studies only to 10 to 12%. Ferrero evaluated variation in rectovaginal endometriotic nodule volume treated with progestogens as monotherapy or combined, or estrogen and progesterone, and or a gonadotropin agonist, releasing hormone agonist plus tibolol. And I like this because there's a combination of progestogens here with gonadotropin. At ultrasonic assessment, nodule volume decreased by around 20% and 30% at 1 year, without significant difference between the study drugs. So the nodule volume decreased around 70% of all these patients. Egekvist in 2017 looked at 238 patients diagnosed with rectosigmoid endometriosis. And he looked underwent primary or secondary surgery were younger than the patient continuing conservative treatment. And he concluded, in a tertiary referral center, where about half of the patients with rectosigmoid endometriosis were scheduled for conservative treatment, more than 80% of these avoided surgery, who continued conservative treatment with progestogens. So we cut 80% of these surgeries in these young ladies. Now, one question will be, would this lady taking the progestogens will have bowel obstruction during medical treatment? And it's very tricky question because there is no much evidence about it. We looked at the complete intestinal obstruction caused by endometriotic stricture is rare, and we found I found that only occurred in less than 1% of this was in 2011 study. Only 1 case of subacute bowel obstruction reported by Andres in 2019, and 2090, great Professor Versellini, Paolo, our great friend, among the case reports searched in the PubMed, 15 additional cases of bowel obstruction during medical treatment use, isolated, and all of them rectosigmoid junction. He found only 15 cases in all the literature. So we need to counsel patients, although it's there, but it's less than 1%. Medical therapy of bowel endometriosis when not to be used, and we need to be clear on this, should not be never used when severe subocclusive intestinal symptoms, if there is stenosis in the ureter, adnexal mass more than 5 centimeters, although I don't have the evidence for that, but all the guidelines talking about 4 to 5 centimeters, and current pregnancy, desire, fertility issue. So what do we have? We have a good arsenal in our hands. Norethistone acetate, which is my favorite drug. I have an experience with it more than 10 years. DMPA more 24 months. Levonorgestrel 5 years, and you can replace it another 5 years and another 5 years. Actually, it's the best drug for women after the age of 35 not willing to have babies. Implanon, we have a short experience with it, up to 3 years, and you can manage many insertions. Aromatase inhibitors, Dynogest, up to 3 years. Gonadotropin releasing hormone agonist, up to 14 months, my own experience, with adding, of course, ADVAC therapy. And I want to share with you, although it's not evidence, but our group in Sydney, and now I'm continuing this, we have what we call the DPS, which is the dual progestin system, or we call the cocktails. We are using Implanon, levonorgestrel together, Implanon, levonorgestrel with Netta, Implanon, levonorgestrel with even gonadotropin releasing hormone agonist for a short time, Dionogest with Levanor and with Mirena, Letrozole with Netta, Letrozole with gonadotropin releasing hormone agonist, Netta with gabapentin, Netta with the tricyclic antidepressant, especially in patients who had chronic pelvic pains that are, and we are using these in cases refractory to standard medical treatment with either oral contraceptives, which I don't believe that they have a first choice. I believe it's progestins. They have the right first choice line in treatment of progestogens. And now we have more than 75 patients who have been satisfactory. More than 80% of them had good result of good quality of life, pain-free lifestyle. And we have submitted this for publication, and hopefully it will be. So, talking about this, Chaperone, our great professor, have talking about it, and today his colleague talked about it. Pain symptoms should be treated without delay because of central sensitization. Medical treatment should be the first therapeutic, and encourage everybody to read this great manuscript by Charles Chaperone. In conclusion, the quality of evidence on medical treatment for bowel endometriosis is suboptimal, but there, and only general conclusion can be drawn. Medical treatment should not be suggested for women who has occlusive symptoms or urethric involvement, or lesion infiltrating more than 50% of the bowel circumference, or larger one than more than 3 centimeters. A. Alexander Popov have shown that clearly. Patients should be informed in detail about the advantages, disadvantages, and they should have the right for autonomy and decide what they want. Hormonal drug might control, but not cure bowel endometriosis. We are not claiming that. And approximately 2/3 of accurately selected patients with bowel syndrome, bowel endometriosis will be managed successfully with hormonal drugs, and adding, as I said, medical treatment with potential for long-term should be the primary approach. And I think every woman has her own, let's say, type of progestogen that suits her. So you need to juggle between progestogens and see which one approaching her or satisfying her pain symptoms. Progestogens are safe, they are well studied and generally well tolerated and inexpensive, and may be used for years. The risk of obstruction is less than 1%. Bowel lesions should be checked periodically. However, you need to be vigilant, looking at this, how they are progressing by annual visits. And please, we need to check these patients for, especially if they are after the age of 35, and to keep in mind that although very minimal, but there is a chance for transformation. The use of progestogens combination with or without gonadotropin releasing hormone agonist may be considered, and we need to have more trial for that. With this, I conclude my talk. Thank you.